Wuhan Tongji Hospital, Wuhan Tongji医院. Since Dr. He is from the most high-risk location, he will bring us the situation from the front line fighting against COVID-19. Please welcome his presentation, Impact of COVID-19 Outbreak on Dialysis Access Management in Wuhan.
Good afternoon, everyone. As we know, since December 2019, a severe acute respiratory infection caused by a novel coronavirus began to spread in China. Today, I want to discuss about the impact of COVID-19 outbreak on dialysis access management in Wuhan. I'm He Fan from Tongji Hospital, Tongji Medical College, Huazhong University of Science and Technology. I will give this speech in 5 parts. First, let's talk about the epidemiology of COVID-19. To date, more than 100 countries in the world has spread of COVID-19. Wuhan in Hubei province is the initial areas where the epidemic break out, and is the most serious effect by the epidemic. The cumulative number of infection has reached 67,000 in Hubei and 49,000 in Wuhan. Fortunately, with the effort of the whole nation, the new onset cases reduced to a small number, about 10 to 30 cases every day, and the number of cure increased to more than 1,000 per day. The totally remain cases is about 20,000. So we predict the epidemic will be disappeared in about 3 weeks. Then we will take about SARS-CoV-2 prevalence in hemodialysis center. Dialysis patients are a special group. They deserve more attention because during the epidemiology, they cannot be isolated at home. Dialysis patients have their and their accomplished family members must go between home and hospital regularly, 2 or 3 times a week for dialysis, and they need to stay for more than 4 hours in a crowded, closed dialysis center. That made dialysis patients more susceptible to infection. This figure showed an infection rate of 6,377 dialysis patients in 62 dialysis centers in Wuhan. We can see the confirmed infection rate in dialysis patients is 1.7%, and the suspected rate is 83%. Likewise, here we can see that the dialysis staff also have a high infection rate and suspected rate, with 3.1 and 3.3% respectively. Then we will talk about the current status of dialysis vascular access in Hubei, whether the vascular access will be affected by the epidemic. In this slide, we show the vascular access in use until March 10 in 34 dialysis centers in Hubei. We can see in some of the centers, the catheter rate is really higher than usual. Here we show the AVF rate is 77 and the catheter rate is 22%. Compared to DOPS5 China data, the AVF rate reduced 10% and the catheter rate reduced 10%. This figure shows the extent of vascular access complication during the virus epidemic. We can see flow reduction and the infection of catheter, AVF stenosis are the most common complication. The sum rate is about 10%. Following, let's look at the treatment of VA complication during the epidemic. The total procedure done during the epidemic was 351, in which about 80% is non-tunnel catheter and 10% is tunnel catheter insertion. Just a few AVF contraction, PTA, and AVF repairment has been done during this epidemic. All the procedure was done for patients cannot receive continued dialysis. Some complications, such as stenosis of AVF, were not treated as usual because of the epidemic. So the protection level of procedure was different in different dialysis centers, most of which was done class 1 or 2 level. Finally, we will discuss a strategy for resume operation. Today, with very few exceptions, we have reached the end of the epidemic. We must resume operation for dialysis patients to reduce catheter rate and further damage. Before the patient admits into the inpatient department, the examination should be done in outpatient department to exclude SARS-CoV-2 infection. The examinations include CT scan, blood routine test, nucleic acid test. If all the tests is negative, then we can admit that patient into the ordinary ward. We should restart operation or procedure gradually. We recommend start simple and short-time cost surgery first, such as tunnel catheter, inserting AVF, and single-port PTA. If the epidemic is not severe and there's no patient left because of epidemic, AVG or AVF reconstruction can resume too. We also should increase planned surgery and reduce emergency surgery. To do so, we need to screen all the patients with reduction AVF or catheter flow volume. We should also make an operation list, arrange it according to the occlusion risk. In the epidemic, we should avoid complex surgery and restrict operation time to reduce the infection risk. For patient confirmed or suspect with COVID-19, we should admit the patient into a COVID-designed hospital ward. Non-tunnel catheter is the prior choice for vascular access complication. All the procedure should be done in a negative pressure operation room under textural prevention. Here, I want to summarize what we discussed. The COVID-19 outbreak has much impact on the dialysis access, includes access in use, complication treatment, access, and patient survival. At the end of epidemic, we should resume access operation gradually and as soon as possible. We should take an appropriate strategy to protect from virus infection during the operation. Finally, I want to thank a lot of people. Wuhan is a big city with 10 million citizens. Thanks all the people in Wuhan. They stay at home, stop moving to avoid a virus spread. Furthermore, there were more than 40,000. Furthermore, there were more than 40,000 doctors and nurses from the whole nation came to Wuhan to fight against virus with us. During this people, some muscular access doctor came to Wuhan as a physician. They work in infection ward, such as Wang Ziming from Chongqing and Lu Cengxi from Zhejiang. Thank you all. Thank you for your attention.